All right, guys, we have Dr. Ted Miln from the UK. Dr. Ted, I've been seeing some really impressive work from you. A lot of people have been mentioning your work to me, and obviously your Instagram is really impressive. Thank you for doing the podcast. I'm always excited to talk to new surgeons from the UK. For so long, there's been sort of this notion, or I guess it's sort of like an unspoken thing where people in the UK are always told just travel outside of the UK. Just, there's no good doctors in the UK. And it was sort of like this for many, many years. But recently, the UK has had a surge of really good doctors, really good young doctors coming up. The likes of you, Dr. Manny Matal. Also been impressed by Dr. Egan. You were one in particular that struck my interest because you do FUT, which is kind of rare. How do you come up with who's the better candidate for which technique?
So it's a discussion that you have with the patient. I think fashions come and go in terms of surgery, and it's something that I always wanted to learn, was to have all of the tools at my disposal to be able to make the decision that was in the best interests of the patient. Because I think if you don't know everything, then you're tempted to shoehorn someone into a technique that may not be suitable for them. There's really a lot of variables that go into that discussion. There's some fairly no-brainer cases like female hair transplants, which it's a big ask to get a woman to shave the back of her head to have a FUE. So I personally believe that a very neat strip scar hidden underneath long hair is almost always the way to go with women and hair transplants. But there's also this idea of the lifetime availability of grafts, which is if you start with a FUT, then you can have a second FUT through the same scar and you still only got one scar. You can then a few years later have a third strip through the same scar and you still only got one scar. And then at any point you can have FUE around it, which gives you more grafts to play with over the patient's lifetime. And as you know, really with good ethical hair transplant surgery, you should be thinking and planning in terms of decades ahead of that patient's life. So sometimes I couple that concept with the patient's feelings about medication. And I guess the best case scenario is you can get someone stabilized on something that works like finasteride or dutasteride, and that will preserve their hair for as long as possible. But if they're unable to take those medications, or they take a sort of suboptimal version of it, like the topical or herbal version like saw palmetto, then sometimes you're more heavily reliant on surgery to keep on filling the leaky bucket as they move through their hair loss journey. So if you can preserve as much donor as you can over that patient's lifetime, then that's one reason why I think a good option is to do a FUT.
That pretty much answers my second question that someone asked me, is which is best to start with. So in your opinion, if you're someone who's like, let's say, destined to be an Norwood 6 or above, it's probably best to start with FUT. Because you can maximize the number of grafts.
I mean, it's one concept, but there's a lot of other variables that influence that decision. So the hair characteristics can play a role. So if someone's got very coarse, bristly hair, then that makes it easier. It lends itself to FUE. If someone's got finer hair, but a lax scalp, then that would sometimes lean you more towards doing an FUT, because you can dissect the follicles under microscopes rather than the loops, and you're essentially doing it blind with FUE. You can sometimes get a better result for those technical factors. But yes, planning in terms of long term, sometimes it's appropriate to start with FUT. I certainly don't think it should be dismissed as a viable treatment, but you have to take into account the patient preference as well, their how they like to style their hair, how high they like their skin fade at the back of their head. All of these things, are very nuanced and individualized to the person sitting in front of you. So I wouldn't say black and white is always better to start with a strip or always better to start with FUE, but these discussions that you have to be able to tailor your long-term plan for that patient's hair loss journey over their lifetime.
I really like that you said, it really has to be individualized and tailored to the patient, taking into account their goals. That's something that is so important for me personally. Whenever someone asks me about a surgeon, if there's someone who has a dogmatic view, like this, you have to do this, this is this is always the best because why, it should be more of open to what the patient wants. Like you mentioned, FUT for women. Absolutely. FUT makes sense for women.
But that said, Melvin, one of my favorite quotes is from Bob Haber, one of the long-standing hair restoration surgeons.
Yes, Bob.
Know the rules, but know when to break them. And, not everything applies in every situation. So I recently had a trans woman who'd had FUE already in Turkey, and she had an extensively over-harvested scar donor area. As heartbreaking as it was, we had to shave her hair to do a second FUE because there simply wasn't the donor density to be able to do a strip. It would have left her with a very poor yield from that over-harvested section of scalp if we took a strip. So we had to shave the back of her head and the sides to try and take as much as we could outside of the area of over-harvesting. And I've got a photo of that on my Instagram, which shows the scarring from over a year. I think it was over a year ago that she went to Turkey, that you can still see these really thick.
Let's take a look at that. Go on to the Instagram, Jerry. There we go. Let's take a look at this. Take us through this case here that you did for this young lady.
Yeah, so she'd had an initial hair transplant in Turkey. I think it was over a year ago. And as is so often the case, she'd had poor regrowth from the transplant. The hairline design had been quite poor in terms of its overall macro design. It was sort of neither feminine or masculine. It didn't go quite far enough in terms of giving that lovely oval frame to the face that she really wanted. And the hair that had grown through was very sparse. She had kind of pluggy 3-hair follicular grafts along her hairline. The angles were wrong, and it didn't really meet your expectations. And they'd left relatively little in the donor area to be able to put it right. So I didn't take any hair at all from that over harvested section of the occipital donor area. So we only really had a bit on the parietal scalp just in front of the section that had been over harvested. But luckily, the donor density was good enough in that untouched section that we could still achieve good numbers. And we were able to correct the hairline and not add to the problem that she had with the back of her head.
It was a big visual difference seeing the area that was over harvested by presumably I would assume a hair mill, and from your work it was very clean. The punches looked a lot smaller. I wonder what size punch they used for that case, because the scars looked really big. Like it looked like maybe at least 1 millimeter.
I've got a theory about this as well. And a really common question is, what size punch do you use and what punch design do you use? And I think it's not just about the diameter of the punch, the actual lumen. The design comes into it a lot as well, and obviously how you use it. So if you have a very simple punch, and in some of the clinics, even in London, use nail drills with very, very basic, I won't say the name of the brand, but very, very basic punches, which are essentially a sort of miniature drinking straw that just leave these very cored out, damaged areas to the back of the head. And even if you're using less than a millimeter, it still is quite damaging. But the WAW-FUE system that I use, designed by Jean Devoir in Belgium, it's such a lovely system because it has a slightly flared tip. It oscillates instead of rotates. So it sort of shuffles its way through the skin, and you have to push it a little bit harder to get it through the skin, which means it leaves behind a hole that's smaller than the diameter of the punch. So it's a very, very nuanced, well-designed piece of kit. And if you use sufficient tumescence when you're doing the extraction, then you can actually stretch the skin like a canvas, and then you're stretching it even more when the punch passes through the skin. So when it all goes back to a normal size, the holes shrink with the skin. So that's how you achieve these really small holes when you do the FUE extraction. And obviously, if that's done in a hair mill, they're not really thinking about that. They're just using basic equipment, doing it fast to get home for an early finish, and they're taking pride in it.
It's funny that you mentioned the WA system, because someone on the forum literally asked why you chose the Devoir WA system, which most surgeons that I talk to either use one of two systems, either the Trivellini Mamba system, which has become very, very popular, or the Jean Devoir WA system. And for people who don't know, Jean Devoir, a pioneer in Belgium, one of the first hair transplant surgeons to join Hair Transplant Network from Europe. He's developed an amazing tool. So I'm glad you mentioned that, because I was going to ask you that.
For patients navigating this impossibly difficult industry, it's a good question to ask what equipment the doctor uses, because not necessarily the equipment that dictates the quality of the result, because you can still get a bad result if you're using it poorly. But I think someone who takes pride in what they do will choose the best instrument to use. So, if you're a concert violinist, you would tend to gravitate towards a Stradivarius rather than a cheap Chinese knockoff version of a violin, because you want what you do to be the very best that it can be. So it's not the system itself. Picasso is not remembered for the paintbrushes he uses, but nevertheless, you will choose a quality instrument to produce those results. And I think there's three kind of main ones, and maybe a few more now. But the Trivolini you mentioned, the WOW system by Jean Devois, and the U-graft, any of these kind of new generation devices which have similar principles in terms of how they work. But the difference between that and a very, very basic, sharp, bog standard rotating punch is a million miles off.
On the topic of tools and stuff like that, we've had in the US quite a few surgeons sort of opt for the robotic FUE devices. There's the NeoGraft and the Artis are the two main ones. Most surgeons, and actually, Bob, you mentioned Bob Haber. I had a podcast with him maybe, it might have been 2 years ago, but he talked about the Artis, and he said, when I first purchased it, I would say if you're just starting off on FUE, like you're a surgeon who just started doing FUE, the Artis might be better. Within probably about a month or so, you're already better than the Artis.
I mean, the first thing, I've never actually used the Artis, and my opinion on it is based on talking to a lot of other doctors who have used it and my research into it. So I think when I speak to people who've bought an Artis, it often sits in the corner as a bit of a status symbol more than actually a particularly useful tool. They'll quite often admit to starting off using the Artis, and then the transection rate is around 50%, and then they'll switch to doing it with another device that we know works better. It's not something I'm interested in purchasing. There may be a time in the future where robotics supersedes and gets better than a person, but I think we're nowhere near it at the moment.
I agree, and you actually hit the nail on the head with what was the appeal of the robotic devices. There are some good surgeons that I see get some good results with the Artis. I will be honest and say that. So it is a tool. Unfortunately, it's a tool that's usually used by novices or doctors that aren't really hair restoration specialists. So a question that I wanted to ask you, and it's one that I've actually been asking quite a few surgeons. The emergence of AI, what role do you think it'll play in hair restoration in the future?
Yeah, it's fascinating. I was talking about this with my father-in-law recently, actually, and I'm aware of Tricoscan. I haven't ordered it yet, but I think I find it so poetic, the idea that you can consider the follicles on the head as like constellations in the sky. It's not like blades of grass that grow up randomly in different places. You have a fixed position of each follicle and each follicular unit, and that remains the same over your lifetime as the hair cycle goes through. So in the same way that you can see the plough or the Big Dipper in the sky and you recognize that as a constellation, you can't, as a human being, see the entire sky as a pattern because we don't have the brain power to be able to compute that. AI can, and it can do that with the back of your head. So you can map perfectly what happens to a donor area over the course of a patient's life in hair transplant journey. You can see, where the gaps are. You can see how follicular units grow after you've harvested close to them. If you give any interventions like different punch sizes, drugs, you can use that to have a really, really good look at the donor area. So I'm quite intrigued by that. I think doctors have been skeptical of that in the past because it's all about managing expectations, and you never want to overpromise based on what an AI can generate for you. But I think it's a useful tool if you use it appropriately to be able to have those conversations about levels of density, which is very hard to get across just with a conversation.
I'm going to ask him, but I hope I'm not speaking out of term. There's a doctor in Brazil named Dr. Pittella, who's an amazing doctor. He developed this tool called the Scalp Scan. It takes a photo of your scalp. It measures it, a 360 view, and If you put in the number of, let's say, follicular units per square centimeter that you need to achieve density, it'll calculate your scale, like your precise scale and the precise number of grafts necessary to reach this density. It's so interesting. You could kind of choose the borders to be like a lesser, let's say you use on the top, you want 50% density, and the borders you want maybe 30% density because there's some hair already miniaturizing there. It'll calculate it perfectly. And I don't know, to me, that's amazing.
It's really awesome. And I actually messaged Dr. Pittella about this because I saw some of his reels on Instagram. I was just blown away by it. So I reached out to him to ask him about the precise scale and the equipment. And it's something that I'm looking into getting at some point. I've recently started my own practice, and I've got the freedom to go into these avenues now. And it also incorporates the hair mass index as an idea, which is something that I talk about with patients, which is very important. And it's not just the number of hairs or the number of grafts. It's the caliber, it's the diameter of each strand, and the combination of caliber and numbers, which ultimately gives you coverage. So you can factor that in your precise scale, if I understand it correctly, as part of this AI. And it's just an awesome tool that will help have informed discussions with patients about coverage and appropriate management of the donor area, which is what it's all about.
And you actually touched on something that I didn't even realize. So the hair mass index. So if you're, let's say, like a Norwood 4 with really fine hair, it'll measure that area. It'll measure the thickness of your hair, and it'll kind of calculate exactly how many grafts you need for that area at 50% density. That's amazing. There's a lot of patients that say, well, this doctor told me I can get it done with 2,500 grafts. And this doctor said, well, 4,000 grafts. And so there's sort of a disconnect in what some doctors believe and what some other doctors believe. But I think with these tools is you'll really be able to, the doctors that want to be conservative will be able to say, well, I feel comfortable giving you 35% density. And the doctors who want to be a little bit more aggressive will be able to tune it up to be more aggressive. And you'll be able to say, well, this is the reason why. This doctor wants to give you 35%. I want to give you 50%. And that's debatable. Who's right or who's wrong, I don't know. It's
actually had this conversation today, and I have it multiple times a week. It especially arises where you've got some sort of diffuse thinning over a wide area. And I'll preempt the patient's comments even before they say it and say, if you go to 3 different doctors, they'll give you 3 completely different quotes on the number of grafts you need to achieve this kind of coverage. Because firstly, it's hard to kind of estimate with the naked eye exactly how much coverage you really have when you've got sort of fine hair over a wide area, and how many grafts you need to get you to a point where you've got visual coverage is difficult to estimate. The one thing I would say is that, like you touched upon there, the technology will help inform the decision, but the decision ultimately is that there's a lot of beliefs and practice and culture that goes into that decision, because some people are naturally more conservative, are more cautious, and we all know that certain doctors like doing ultra conservative work, and that's fine. And there are other doctors who do more, I would say aggressive, but more kind of dense frontal thirds. They'll do temporal points. That all of those factors will still exist. There will still be different doctors that have different preferences on what a airline should look like and how you meet those needs of the patient. But you'll have more tools at your disposal to be able to have those informed discussions with patients.
Let me ask you this. So since, there's different, and what I like to say is that there's some surgeons that are more cautious, conservative, and they think more about like long term. And in that, they try to base their decision on, how are you going to look 10, 20, 30 years from now. There's also other surgeons that they calculate it differently. They look at things differently. They're looking at it long term, but the way they do things is different, and they push the boundaries more. So they'll push the boundary and say, well, I think I can do this many grafts, really dense pack and get your hair looking, doesn't look like you had hair loss. What school of thought do you find yourself in?
I think you need to have the ability to do what you need to do to meet the expectations of the patient. You might have a personal preference about what the patient should look like and what they should be aiming for. But I think it's so important to define what success looks like in their eyes. And I mean, the consultation I just had was with a patient who is a singer. He performs on stage, and the underlying reason he's wanting a hair transplant is because he doesn't like the light reflecting on the top of his head when he's on stage performing, and it puts him off being able to give his best concert because he's avoiding certain conditions or certain areas of the stage where the lighting is particularly bright. And I think that's, for a lot of people, it's hair loss is a sort of thorn in your side that gets in the way of your enjoyment in the things that you should be enjoying. So, if you take that as an example, it wouldn't really solve his problem to do an ultra conservative, sparsely paced forelock, for example, because he would still have that light reflecting on his head as he was performing in his concert. So I use a deep understanding of the patient to inform my decision on how aggressive to be. In his case, he's not particularly interested in a 17-year-old's hairline, but where he does want hair, he wants it to be dense. And I think you need to, as a surgeon, have the ability, the raw skill and the experience to know how to create a very, very dense result in the situations where you need it. So I would take myself and my personal preference out of the equation and just work to understand what it is the patient really wants, and then be able to give it to them if it's appropriate to do so.
Right. No, I agree with you. I mean, I think there was always been sort of this old school thought of like, some hair is better than no hair, and you can always come back and get more hair if you want it. But that to me kind of puts the patient in an undesirable situation, right? Because you have surgery. Yeah, you look a little bit better than you did before, but you're still not satisfied. So, I feel like in a situation where it's possible to do it all in one go, you should, right? Obviously, if you're like a Norwood 6 or something like that, that's not always feasible. If you're able to do it and dense pack it in one go, I don't see why you wouldn't do that. That to me doesn't make too much sense. But I can respect doctors that want to be very conservative and they don't want to over harvest the donor, and they're it's a very fine line between getting the best result on top while maintaining optimal conditions in the
Again,
donor.
it boils down to being very, very open with the patient and giving them the tools for them to make their choice. And the other similar conversation that comes up is, you're very young to have a hair transplant. Go away and you come back when you're older. And I get it. I understand that you need to be preserving the donor area at all costs. It's your precious finite resource of hair that you have to be able to achieve your results over your lifetime. And there are certain situations, obviously, when you need to see how well medication works first, how it progresses, and use that to inform your decisions. But I think it's slightly patronizing of doctors to insist that you can't do this, because in your mid-20s, it's an important part of your life. You're looking to find a partner, progress in your career, and having your self-confidence sapped from you at this pivotal stage of your life can change the trajectory of your life. And I think as long as you explain in graphic detail the pros and cons of the approach, and you help the patient make an informed decision, and you're convinced yourself that they have understood it and they're making those decisions in good faith, then I don't think it's right to have these hard and fast rules that prevent you doing something that might be appropriate.
You're a step ahead of me. Somebody wanted me to ask you about, age, what's the best age for a hair transplant, or what is the cutoff age for a hair transplant? I've always sort of thought that right around 24, 25 is a good starting point. Under that, like 20, 21, it's really difficult to kind of assess where you're headed, because around that age, a Norwood 2 and a Norwood 6 can look the same, right? Two guys could be, one guy's destined to be maybe a Norwood 3, Norwood 4. And the other guy is going to be Norwood 6 by 30. At that maybe 19, 20 age, they look pretty much the same. So if you're too aggressive with the guy who's, 20, one guy may turn out okay, the other guy may be disastrous. How do you navigate that? What's your preference or your cutoff point?
I mean, I don't think I've ever operated on anyone under the age of 21. And you're absolutely right. I guess what you have in your toolkit to know what that lifetime trajectory of hair loss looks like is how far they've moved along that trajectory so far. In other words, how old they are and how bad their hair loss is, and their family history. Clearly, in an example where, let's say a 22-year-old has got, a huge family of 9 brothers and countless uncles, and they're all Norwood 7 by the age of 30, and he's already got advanced signs of hair loss even at that early age. You're going to have a lot of confidence that he's going to have a very aggressive form of hair loss that will lead to Norwood 7 by the age of 30 alongside all of the other members of his family. So, that informs you. And clearly, the older you are, the more of that life trajectory that you've already lived. So if you've got some early, frontal recession when you're in your 60s, well, you've got to 60 and you've only got, lost a little bit. So you can be more confident in being a bit more aggressive. And the other factor that goes into the consideration is what the person is like sitting in front of you, because there are some 22-year-olds who are taking oral dutasteride, oral minoxidil. They understand it. They absolutely get it. And they're a member of the Hair Restoration Network. They follow everyone going, and they understand the need to preserve their hair as best they can. They've perhaps taken these medications for a year already, demonstrated that they haven't got any side effects from them, and they understand what's at stake. And equally, there are 30-year-olds who think that there'll be a one and done type of procedure where they don't need to do any preventatives themselves. They're not interested in medication. They have unbelievably high expectations, and they think that they'll just have a transplant and it'll solve their life problems, and totally unrealistic. And you can see, using those two extreme examples, in a sense, despite the chap's young age, you have a little bit more confidence engaging with someone, a 22-year-old who's very well informed and is already taking steps to mitigate their future hair loss, than someone who's totally unrealistic at a later age.
I have to say I agree 100%. If you're 22, you've been explained what can happen in the future if you don't take medication. Exactly like you said, what's at stake. If they've agreed to that, they're willing to stay on medication, they're educated on that. I guess in that situation, there's always exceptions to the rule.
I don't want you to think that I would just do what a patient asks me to do. And it's not just what the patient says, because any 22-year-old who's losing their hair will impress upon you how important it is to get their hair back. And it's not enough just to take their word for it. You have to build a little bit of a relationship with them, understand their thought process, their decision-making ability, and actually be reassured yourself that they are committed to this, that they will do the necessary steps, that they have understood it, and they're not just saying what they think you want them to say in order to get the outcome that they want. And there's a big difference there. I'm not a believer, just to be clear, of just being a yes monkey to young lads who want hair transplants. I believe in fully equipping people to make decisions, and then really understanding their thought process and whether they're on board and they really get it. And if they do, then I think it's, as you say, it's reasonable to give them a chance.
If a patient comes to you and they want their hairline repaired, what's your protocol for that? There's a couple of schools of thought on how that should be managed. Some surgeons want you to do, laser epilation, remove those grafts through laser, accept that those are gone. Some want to punch it out. Some surgeons are more inclined to punch out the grafts and then at a later time do a hair transplant. And others are more inclined to camouflage it, add grafts in areas to really try to make it the most natural it possibly can without removing those hairs or losing those.
Yeah, I mean, all of the above. I think all of the strategies you mentioned are valid strategies in the right context. I mean, I'm in discussion with this chap from America, actually, who's had a pretty disastrous looking hair transplant. It's very, very coarse. The angles are bizarre. And
I think he would fall into the category. The one blessing is that it's not too low. You don't think you have to remove huge quantities of grafts. In that sort of situation, I would tend to overwhelm it. So I would, take grafts selectively without contributing to the damage in the donor area, and I would position them in an appropriate direction, matching what's left of their native hair, and then that kind of, I guess it sort of steers the existing hair, or it camouflages it, as you say, and that can give a very nice result. I think if you've got a completely wrong hairline, as in if it's just like, into your frontalis muscle or a bizarre shape or completely asymmetrical, then you have to remove hairs in some way, and whether that be through electrolysis or through usually punching the grafts out. And that, if you have to punch out a significant number of grafts, then inevitably that becomes a two-stage procedure. So you remove the grafts you can. I see that Dr. Bisanga has started using an electrolysis machine to, after he has punched out those offending grafts, you can then use electrolysis to kind of zap the last few little wispy ones that you might have not been able to punch out. But anyway, you want to clear your field, let everything heal, and then go back in perhaps 6 months later and design an appropriate hairline, do it properly, have the sort of feathered edge with the soft singles along the edge so that it looks good. And what I would do with those grafts that I punched out, I'd usually place them further back so that he hasn't lost any hair. They're waiting for you to go back and correct it.
There's a few surgeons doing the electrolysis now. Dr. Pinto mentioned especially for patients that need a massive amount of grafts to be removed, because there's always the concern of scarring. Even though the face usually scars better than the scalp. I've had 1,600 from under my chin, and even if I shave it, I don't know where they were taken from.
I was late to the party with using beard as donor for that reason. It just sort of terrified me of leaving very noticeable scars on someone's face. But I've done it quite a bit of times now, and it's amazing how well it heals and how unnoticeable it is. And it's a similar thing usually with misplaced grafts along a low hairline. I think you've got to weigh that up against your instinct as an ethical hair surgeon, which is never to waste grafts. It's heartbreaking to use electrolysis to actually destroy perfectly good hair that you could use to contribute to a better result for the patient. But I quite like Dr. Bisanga's approach, which is, use both. Harvest what you can with a punch to remove the offending pluggy frizz along a hairline, and then if there's still the odd hair that you don't want to give them a scar, you can just remove those with electrolysis.
Before I let you go, I wanted to ask you one question that has been sort of the community would be upset at me if I didn't ask you. Have you heard about Verteporfin?
Yeah.
The drug. So I actually had a podcast last week with Dr. Bisanga, and for probably almost over a year, I've been asking him, will you do a trial? Will you do a trial? And he's been saying, no, ACell, ACell was a thing back in the day and it was the same thing and it didn't work. And so he was very, very skeptical, but he's agreed to do it. He said, look, if there's enough demand from the community, obviously patients are interested in it. I'll do it just to see how it works. I'm not going to promise anything. As a matter of fact, I probably think it doesn't work, but we'll see. Would it be something that you'd be open to trying?
Yeah, I've actually thought about doing my own trial. There's this really interesting idea, right, which is everyone works on the basis that the donor hair at the back and sides is finite, which it is. But I think it was Jean Devois that presented something recently, which, sometimes when let's say you have a 3-hair follicular unit graft and you remove 2 of those follicles and you leave behind 1. Well, every now and again, sometimes that 1 will recover as a 2, and that is hair that has kind of, has come from nowhere because of the stem cells that remain in the skin. And what I'd be really intrigued, based on the hype around verteporfin, is, can you improve on that a little bit? Is it possible with the healing qualities and the effects on scarring that it has an impact on the recovery? So you can, with AI, you can now look at that in more detail, and I'm very interested in it. I haven't really done any
taken any steps to research it, but I'm following it with keen interest.
Would you be open to possibly being in a group chat with Dr. Bisanga and Dr. Barghouthi?
Yeah, absolutely.
Yeah, I would love to get, some more people on board. I know that in the forum, it's the largest thread we've ever had. It's literally, I get lost with so many posts. I mean, it's like, I don't know, 3,000 posts on the Verteporfin. It's so many people that are interested in this, and it's really global. It's a global effort. Even if it grows back 20%, that would be huge. That would be, groundbreaking.
And theoretically, you could have a staged approach where you do smaller procedures, every couple of years. And if every time there's a small percentage of regrowth, then you still end up with a stock of new hair that's come from nowhere that you have available to you, in your lifetime availability of graft number that you can use to contribute to their density. So it's very exciting. And I'm very up for it. And I think also what's interesting in this sort of situation, you can potentially use patients as their own control group. So you could take the left side of someone's head and apply verteporfin and not to the right side. And then you can use your AI to look at exactly what's happened to both sides in incredible detail and statistically analyze it to see what difference there's been, if any. And it's exciting.
Part of the importance of having like a group chat and like among doctors is to kind of bounce ideas off of each other, and I think kind of come up with a protocol, because Dr. Bisanga had some very good ideas, and I'm sure Dr. Barghouthi would want to implement those ideas. And if you can get 3 surgeons doing 3 trials simultaneously, all with the same protocol, then you're really dialing into something, and then you can really look at the data, and there's less variables now because these doctors are following the same protocol. So it would be interesting. I'm excited that you said yes.
I mean, like everything, you have to do a lot of expectation management. There's just because it's just an idea at this stage, really. You need the data to be able to back up any kind of change in clinical practice. But if you have that clinical equipoise, in other words, if you don't really know and it's worth doing a study, then I think one thing that's really lacking in the hair transplant world in general is big studies, because everyone has their own little clinic dotted around the world. And maybe the hair restoration network is the key piece that can get the sheer numbers from a multicenter trial to be able to actually produce meaningful data.
Dr. Ferrer actually reached out to me, and he's the scientific director for, I believe, the WFI this year, and he's asking for more surgeons to come and talk about the verteporfin, surgeons who've tried it. So obviously that's going to be a huge audience of surgeons, and maybe more surgeons will get on board. I'm really trying to get something set for the ISHRS conference this year in Denver. Will you be there?
Colorado,
yeah. So we're actually trying to set something up, maybe a luncheon or something, to get a group of doctors and really get everybody on board with this. It's something that I'm willing to invest in my own money. Nobody's going to make anything off of this, but if it's something that could be beneficial for patients, it's our duty. It's something that I, personally, as a patient, it's something that I'm eager and interested in.
If it's worth doing, then there should be some sort of grants available, like the ISHRS offer research grants. And if it's such an unanswered question, and so many people are interested, then there should be some kind of funding from these organizations to help support that.
What would you say the biggest problem is with patients going to a hair mill? Like, if I'm a patient and I'm saying, well, I'd rather pay 1,500 pounds to this place, what could go wrong? A lot of people, even surgeons, have said, what could go wrong with a hair transplant? Yeah, worst case scenario, it doesn't grow. Is that true?
Absolutely not. I mean, a fairly brutal way of answering that question is, I came across a chap who contracted hepatitis from a hair transplant in Turkey. And, people say that, the worst thing that can go wrong with a hair transplant is it doesn't grow or it looks bad, in which case I'll just shave it off. You can't shave off hepatitis. There was a case from a dermatology colleague of mine recently who
had this chronically infected result after someone came back from a hair transplant abroad, and it turned out to be TB of the scalp, which is some medieval kind of stuff, and and so many things that can go wrong. It can leave scarring, in disfigurement on your face. Another patient I had was this poor lad who'd broken up with his girlfriend. He was early 20s, emotionally vulnerable following this breakup, and he went to Turkey and they upsold him a beard transplant. So they decimated his donor area, gave him a ludicrously low, dead straight hairline full of threes along his frontalis muscle. And then he had this horrible scarred kind of pustule, beard transplant. And it was technically just such a difficult thing to begin to know how to fix. And his life, is ruined from that in many respects. And he will never have his donor area back again. They've used so many grafts badly. It's horrifying. And I think people desperately need to know that it is not a case of you can just shave it off and what's the worst that can happen, because a lot of bad things can happen.
Before I let you go, Dr. Miln, where can people find you and how can they contact you if they want to get a hold of you?
So I've recently set up my own clinic, and until my website goes live, which will hopefully be soon, the best way that I engage with all my patients at the moment is Instagram. So if you just DM me on Instagram at Dr. Ted Miln, then you can see all of my before and afters that I post. You can see some of the images we've referred to during this conversation, and I'm always happy to answer any questions. I'm all about sort of educating and informing. So just feel free to reach out.
Thank you so much, Dr. Miln.